All right, I'm back for part two, my prompt two for this final video project, and we're going to be talking about Wigger's diagram, how it relates ventricular volume, EKG, and pressure all together, as well as after we talk about Wigger's diagram. We are going to talk about atherosclerosis and the pathophysiology behind it and how it can actually affect Wigger's diagram and how we can see that on Wigger's diagram. So you have EKG. I went ahead and just found a picture of Wigger's diagram to make it easier to visualize instead of me just talking about it. We have the EKG down here. We have the pressure up top, and then we have volume down here. And so one of the first things to look at on Wigger's diagram is EKG, the depolarization signal, the P wave, QRS complex, all that. And so you can see whenever we start the EKG, this is the P wave, and the P wave signifies atrial contraction. And so we can kind of visualize that in the volume aspect as well as the pressure aspect. So whenever atrial contraction is supposed to be occurring, the atrial pressure should be going up, which I believe, is the yellow. So atrial pressure. Atrial pressure is indeed going up, so we can correlate those two to prove why it's happening, as well as the volume of the ventricles is also going up because as your atrium are contracting, more blood is going into the ventricles, so that's proven. And then so the SA node depolarizing is over here, and then right here is AV node delay. AV node delay can be signified using the other two, as you can see. After the atrium is done contracting in the AV nodal delay, you see a decrease in pressure, which proves that, as well as a maintaining of volume because no contraction really, or you actually get a slight increase because the AV nodal delay is to allow for more filling, so you do get more volume, but you get lower pressure. And then you get to the QRS complex. The Q is to show the bundle of His and bundle branches. And so we can prove that because during the bundle of His and bundle branches going, there's actually no change in pressure because there's not a lot of myocardial mass in the bundle of His and bundle branches. It's just sending the signal to get down to the Purkinje fibers, as well as there's no change in volume as well. And then the RS complex is the Purkinje fibers going. And so we can prove that because whenever the Purkinje fibers are firing, we get a high increase in pressure, as well as the mitral valve is closing to cause isovolumetric contraction. So basically, the ventricles are contracting, but no valves are open, so the blood's still in the ventricles. That's why it's called isovolumetric, because no blood is leaving. We can actually see that in the volume as well. There's no change in volume, but we see a high increase in pressure. So that's how we're able to prove that the Purkinje fibers are firing. Hold on. And so we can also see this as the yellow line, the atrium. It shows a little S wave right here, and that's from the high isovolumetric contraction is actually kind of forcing it into the atrium. The pressure is expanding, and so it's poking a little bit into the atrium, so that's why you see a little increase in the atrial pressure because of the extreme amounts of contraction and force in the ventricles. And this isovolumetric contraction is occurring to get a high enough pressure to allow the aortic valve to open to basically get higher than the afterload to open that valve to then allow for the flowing of blood out into the aorta into the rest of the body. And then P wave, and so we'll go back up here. Once that isovolumetric contraction, so this is actually aorta pressure. Once that isovolumetric contraction reaches a threshold, the aortic valve opens, and pressure keeps increasing along the ventricles because of the increased force, increased contraction to get this blood out now that the valve is open. And aortic pressure also actually increases because the blood is flowing into the aorta, causing increased pressure. And both of them reach a kind of apex up here where they are continued contracting, and we can prove that down here. So whenever you look at the volume, whenever the aortic valve opens, you see a massive drop off in the ventricle volume up until a certain point. And the contraction, the pressure up here stays high, even though there's not as much blood. And the blood, not the lack of blood, is causing the gradual dip, because the ventricles are still contracting up here, and that's why the pressure is still so high, even though there's not as much blood. And then, if you look down here, the P wave starts for the ventricular repolarization right around whenever the contraction stops. So we can prove that as well. And the blood volume in the ventricles is low whenever the P wave is starting. So that's proven. And the pressure for the aorta drops off right here. And it actually, as it continues, it starts decreasing because there's less blood in the aorta because the valve is closed. So it keeps decreasing until your next cardiac cycle where it repeats. The ventricle pressure starts to, once the aortic valve closes, have a massive dip because you are losing the contraction now. And it dips back to the regular pressure as it kind of was at the beginning, where it goes until the next cardiac cycle. And then the passive filling right here. So we can prove the passive filling is happening because if you look at the EKG, there's nothing signaling for a contraction occurring, and there's no systolic wave or any contraction signal, as well as the pressure. There's no pressure increase anywhere on the pressure thing, yet the volume is increasing significantly because of the diastolic filling of the ventricles. So that is proven there. And that is how you look at Wigger's diagram and be able to tell and relate EKG, volume, and pressure as it comes to the cardiac cycle. And so now we're going to look at atherosclerosis and how it relates to Wigger's diagram. So first we're going to look at what a normal blood cell looks like before it gets atherosclerosis. So this is just a normal blood cell. You have an epithelial lining of cells that can allow passing through the blood cell to the outside. But normal blood cells just go through the blood vessel at a normal rate, nothing blocking it, so it has free movement. And then, however, whenever atherosclerosis is happening, it's happening usually along intersections. So whenever a artery is splitting into two different pathways, the blood cell will come down. And it's not really like humans, how it can veer one way or the other. Sometimes it just hits into the corner like that. And this will cause a inflammatory signal that will cause a downstream effect and cause the atherosclerosis. And so how that happens is actually you have a phospholipid bilayer on most of your cells pretty much. and this red blood cell is going and hitting it at a ginormous force. And so what's going to happen is CPLA2, whenever this red blood cell hits, is going to go and cleave arachidonic acid off of the phospholipid bilayer, which then starts a signaling cascade to signal PGH2, which is basically a prostaglandin, as well as leukotrienes, which both then stimulate the inflammatory signal. And this inflammatory signal is huge because let's go and we can now look at the affected, the atherosclerosis blood vessel. So you have your red blood cell and it's traveling through. However, that signaling cascade or that inflammatory response would have happened, like, let's say over here. And so that inflammatory response would signal for macrophages or monocytes to come to the inflammatory response to eat up, the things causing the inflammatory response. And so we have these small dense lipoproteins, SD-LDL, that are very small and very dense, and they are actually able to get past the epithelial lining and get out of the blood vessel. And so these macrophages, these monocytes, whenever they come for the inflammatory response, they see this SD-LDL and they actually follow it into, like, past the epithelial lining, and they actually go and engulf this SD-LDL. I forgot to mention that the SD-LDL gets oxidized whenever it comes to past the epithelial lining, and whenever it engulfs the oxidized SD-LDL, then it creates a foam cell, which is actually what is deposited at these atherosclerotic lesion type things. So these foam cells create these protrusions into the blood vessel. And it causes the regular blood vessel that's trying to get through in this atherosclerosis cell, this blood vessel, now it only has this tiny region up here to get through, so it's not as effective as getting through, which will cause hypoxia and even possible muscle tissue death because of lack of oxygen, the hypoxic. And so that will overall affect the heart, the blood pathway and everything like that. And so overall, this will if we relate this back to the Wigger's diagram, we're going to predict that atherosclerosis is going to increase the afterload because it's going to increase blood pressure. If the blood can't get through this little spot right here, blood is going to pile up at the in the blood vessel, overall increasing blood pressure in the arteries, which will lead to hypertension, which overall is going to increase afterload. And what's going to happen is if we increase afterload, instead of the aortic pressure being right here, let's say it gets moved up to right here. That will mean that more isovolumetric contraction, more isovolumetric force is going to be needed to get the ventricle pressure up higher, which will also mean that it will close sooner, so you get less time for a ventricular systolic force to get out into the blood vessel, which will cause less blood, less oxygen, and overall lead to the cycle of hypoxia. As well as you will see impaired relaxation. So, due to diastolic dysfunction, you your left ventricular or your left ventricle will probably get over hypertrophied from having to work harder to get this isovolumetric contraction to get to the higher pressure. So having a over hypertrophied left ventricle will cause impaired relaxation because it will probably be more stiff and less elastic. The plaque rupture, the rupture of this plaque could also lead to a possible myocardial infarction, which will then also lead to a cause of contractile tissue and possibly even a HFrEF heart failure. And overall, over time, atherosclerosis leads to an increase in cardiac workload, hypertrophy, and can even cause heart failure over time. And that's shown on Wigger's diagram through the presence of that afterload and overall the overworking of the heart to compensate for the atherosclerosis and all of that. But thank you for listening, and again, sorry for my voice. I've been sick recently, and I was trying to wait till the last moment to record these videos so that my voice could get better, but thank you.